Okay, I'm going to be talking about non-infectious pulmonary complications of HIV. It's not the most exciting topic, but I think it has some important points that it's worth mentioning. So I'll try and make it as relevant and exciting as possible. So the objectives of the talk is going to take a little bit of time to talk about HIV epidemiology and HIV-associated non-infectious complications. I found the most common and the most relevant are malignancies, talking most about Kaposi sarcoma, which is the most common, and then talking a little bit about emphysema, and then probably a little bit about interstitial lung disease. I'm not going to spend a lot of time about that, or about pulmonary hypertension. So the epidemiology of HIV has changed. Recently, the CDC says that there's about 1 million people living in the U.S. With HIV, and this is a graph that shows that the number of people living with HIV has been increasing. You see, in 2012, it's 35 million people do live with HIV compared to 2001, which is about 28 million people, and this does reflect a global initiation started by the United Nations in early 2000, and the aim is in 20-30 years to eradicate the epidemic or HIV, and it's starting to move the curves a little bit, as we can see from the next slide that showed the new infections globally from HIV has decreased. In 2012 it's 2.3 million, and the curve is going down, and it's about 33% decline. And those years, it's reflecting there's a 15 years plan to do some results, and it's working. That the graph is going down regarding new infection. And one of the other, the global aim is to eradicate the HIV epidemic, but the other also is to increase the people living with HIV, decrease the number of new infection and deaths related to HIV. And you can see that here that the deaths related to HIV has decreased. The curve has started getting down. And then 2012 there was about 1.6 down from 2.3 million people dying from HIV. So it's becoming more a chronic disease, and we're trying to go into the seeing it eradicated epidemic. The common malignancies that we can see with HIV are the most common is Kaposi sarcoma, Non-Hodgkins lymphoma, non-small cell lung cancer, and multicentric Castleman disease. So we're going to spend a lot of time about Kaposi sarcoma, which is the most common HIV-associated malignancy. So these are some of the standardized risk about cancer and HIV compared with transplant recipients, and you can see that's about the same. Some of them will be higher risk in AIDS patients compared to the transplant, but you can see the resemblance about the cell-mediated immunity decrease, and the cancer risk will be elevated. And the top three is the age-defining cancer, we call them Kaposi, cervical in females, and Non-Hodgkins lymphoma. So this graph represents the trend about age-defining malignancies. So the top graph here is all the age-defining malignancies is coming down eventually, and you can see here it's the mid-90s, and here we have the antiretroviral therapy started. So you can see that the age-defining malignancies have decreased with antiretroviral therapy, and the most common is this graph, which is the Kaposi sarcoma graph, compared to the non-age defining malignancies, which is the lung cancer is the most common. It continues to rise despite the antiretroviral therapy, and in fact there is some loose association between the medication itself and possibly causing some of the cancers to go up, modulating the immune response and the inflammation and the cytokine, and making the body less defend less against the cancers. So Kaposi sarcoma is the most common HIV malignancy. There's two types of the Kaposi sarcoma is new with the epidemic of HIV. The endemic one in Africa, which is known in the sub-Saharan Africa, it's usually more in females, and it's usually as a consequence of infection of human herpes virus 8, and that's endemic in that part for a long time. And the one we're seeing is the Kaposi sarcoma epidemic with the HIV epidemic. It's noted that 90%, it's important, 90% of cases are with men who have sex with men of the Kaposi sarcoma. Compared to the endemic part of the African one, it's more prevalent in females compared to the males one. And etiologically, it's very associated with HIV infection and also infection of a human herpes virus 8. So the incidence has declined markedly, as we said, as we have seen from the graph with the introduction of antiretroviral therapy. The incidence is noted to be higher when you start the antiretroviral therapy, because when you give that antiretroviral therapy, you either do unmask, increase the immunity, so you unmask a present Kaposi sarcoma, so the body will recognize it, it will flare it up, and you'll have symptoms from that Kaposi sarcoma, or possibly because your patient is already severely immunocompromised, and he will have you will give him antiretroviral therapy if he's an AIDS patient, and he will probably be severely immunocompromised and will have more risk to have Kaposi sarcoma. And this is the most common and the most important risk factor associated with the development. And you can see it's CD4 count below than 200 is the most relative risk associated with development of Kaposi sarcoma. Corticosteroids, the same thing. If you have a patient, you give him corticosteroids for another reason, PCP infection, and you might induce a flare-up of Kaposi sarcoma, or so you have no symptoms, and then you'll start coughing, bringing up phlegm or hemoptysis. Probably he did have a hidden Kaposi sarcoma that's been flared up. Also, it's been reported that patients who get opportunistic infection, there's a lot of cytokines and inflammation that may also expose a present Kaposi sarcoma. That might be the first presentation. Also, if you notice that a patient with Kaposi sarcoma and those patients are on steroids for some reason, if you pull back the steroids, the Kaposi sarcoma may improve. This is one of the treatments. It can involve any side of the body, universally any side of the body. The most common presentation is the mucocutaneous presentations, and you can see it's violaceous, it's red, most of the skin and the mucocutaneous part. The pulmonary Kaposi sarcoma has been detected in 15 to 30% of cases of patients of known Kaposi sarcoma, and it's very rare, or I would say it's rarely present as an isolated pulmonary Kaposi sarcoma. If you have a patient with pulmonary Kaposi sarcoma, most likely he's going to have it somewhere else. The endobronchial part of Kaposi sarcoma probably is going to present with it could be asymptomatic, it could be cough, wheezing, hemoptysis, or we could have airway obstruction. You can see some of the red lesions. We'll talk about the histopathology later. The parenchymal lung involvement, also symptoms could be non-specific, especially in the HIV patient: dyspnea, cough, hemoptysis, fever, fatigue, hypoxemia. The pleural effusions could be secondary to patients with parenchymal Kaposi sarcoma, will present with effusions, exudative effusion, lymphocytic, and may occur rarely as an isolated Kaposi sarcoma presents as pleural effusion, malignant pleural effusion. The diagnosis is most likely or most often done as a clinical diagnosis, and the reason is there is probably 25 to 30% risk of bleeding when you biopsy those lesions. So everybody's kind of hesitant to biopsy a Kaposi sarcoma lesions. By definition, they have spindle cell proliferation and a lot of angiogenesis in those in those tumors. So you can make the diagnosis presumptively. If you go with the endobronchial scope, you see Kaposi sarcoma in the mouth, you go into the airways, you see the typical lesions, and you do a CAT scan or X-ray, there is parenchymal lesions, you excluded out infection, and you think that the clinical picture fits in, most likely he has Kaposi sarcoma, you can diagnose it that way. If the picture is atypical, you might need to do a biopsy, but there is a bleeding risk. The pathology will see spindle cell and angiogenesis. You'll see that in the histology, and they will do PCR for the HHV, human herpes virus 8, on the biopsy sample. So that will be also help in the diagnosis. Non-specific also on the chest X-ray, reticular nodular opacities. In an HIV population, of course, ruling out infection is the first major concern. So it doesn't ring any specificity or ring any bells in relation to Kaposi sarcoma. On the CAT scan, they might be a little bit more specific or thinking about it. If you see some nodules going with from the parenchyma towards the hilum, could be masses or nodular densities or discrete nodules. It sounds like, in a way, like a sarcoidosis goes with the bronchovascular bundles, like a nodule part along that way. Could have pleural effusions, but of course you have to do the BAL, rule out the infection. It could be infection which presents atypically in a HIV patient. So this is what we said. The role of bronchoscopy is obtain BAL samples for microbiologic stains and cultures. You would do immune stains for infections, cytological examination for viruses, inclusion bodies, and you might do also testing or cytological examination or even biopsies for tumors, but you might do it to rule out other tumors than Kaposi sarcoma. The diagnosis of Kaposi sarcoma cannot be made on cytology. You need that typical pattern, angiogenesis and spindle cell proliferation, to see it in the architecture to have a diagnosis, and you will stain that sample for HHV virus. Endobronchially, you'll see it's violaceous, bright red. It will be macular or papular. Common sites are the mucosa of the lower airways at branching points. It could be in the trachea, less commonly. Of course, could be anywhere. So you will see the lesions. This is the red lesion here. Could be excuse me. Could be a macule or an endobronchial lesion. So the first thing, you want to bite that with a forceps, but remember about 20-30% risk of bleeding from there. So if it fits in the clinical picture, you made the diagnosis, you do not need to bite it. Bronchoscopy, transbronchial biopsies, not endobronchial, sorry. Transbronchial biopsies have low diagnostic yields, been reported about 25%. Significant hemorrhage about 30%. This is the microscopic picture. You'll see the spindle cells over here, and you'll see the angiogenesis over here, and this could be stained for HHV, herpes virus 8, PCR, and you'll have your diagnosis. And as we said, it could be clinically only. The pleural Kaposi sarcoma, it's most likely associated with the parenchymal part having an exudative pleural effusion. No specific findings on the analysis, usually exudative. Pleocytosis, lymphocytic pleocytosis, and a high LDH. Cytology, as we said, is negative. You can't diagnose this or catch it on cytology. You need the actual biopsy. So the main role of thoracentesis will be probably rule out infection. If you catch a cancer other than the Kaposi sarcoma, you might catch a lymphoma. If you do a cytology instead of, you're not going to be able to diagnose the Kaposi sarcoma. You'll find the lesions on the visceral, not the parietal part of the lung. Prognosis. So do they live long or not? Probably not. This is the HIV patient prognosis, Kaplan-Meier curve, and you'd see that this is patients with HIV with Kaposi sarcoma, and 50% of them lived probably, 3 years. So not great.
Once it comes as pulmonary, isolated the lungs?
It rarely comes isolated. It's very rare to be isolated pulmonary Kaposi sarcoma. This is part of the atypical presentation. By that part, you probably not going to see a CAT scan that's going to say this is Kaposi sarcoma. You probably want to do biopsy or even VATS, because it's not fitting as a typical feature of Kaposi sarcoma that you can diagnose it. So probably it's atypically, and you want to pursue biopsy instead of clinically diagnosing it.
What's the main symptomatology? Hemoptysis?
It's very, very non-specific. Cough, shortness of breath, hemoptysis, and the most time it's done as you see the patient. You'll probably going to see it in the nose, in the mouth, in the hands, in the extremities. It's rarely going to go, and sometimes we'll be surprised you'll find it in the bronchus. And with a patient with AIDS, the CD4 count probably less than 200. 50. Okay, this is a Kaposi sarcoma lesion. It's in the tongue. It's probably part of the general picture instead of isolated findings as a pulmonary Kaposi sarcoma. But it's been reported as presenting like that. It's been even reported as presenting as a pleural effusion of Kaposi sarcoma alone. So I'm sure it's going to come from somewhere, but nobody detected it, like a lymph node or lung parenchyma. So treatment of pulmonary Kaposi sarcoma, the mainstay, as we said, that the antiretroviral therapy. Patient is asymptomatic, is doing okay, just give him antiretroviral therapy and he'll do better. No indication for chemotherapy. If the lesions are progressing or the patient is started to get symptomatic, and you might need to add chemotherapy. For patients being on steroids, you might start antiretroviral therapy, withdraw steroids, stop steroids, they might do better. Treatment of the obstructive endobronchial lesions, they can do any endobronchial lesion, any obstructive lesion, laser, rigid bronchoscopy, radiation or laser, or if it's big stent. Hemoptysis may require local therapy, laser, cryo, balloon, if it's severe. So it's not specific for that particular indication. The management can be tricky for the pleural effusion. You can treat it as a regular parapneumonic pleural effusion. You can drain it, drain it, and do some testing on it. But sometimes it gets difficult to treat because they tend to recur, and so you'll end up either doing a palliative indwelling catheter or you can do a pleurodesis with very variable success rates for the pleurodesis in this indication. The indwelling catheter probably is also the not greatest idea in HIV/AIDS patients with a CD4 count probably less than 200. So it's kind of gets in the tricky part. And depends on the prognosis. As we said, most of them, half of them will not finish 3 years to live. The second common cancer in the HIV population is non-Hodgkins lymphoma. It's an AIDS-defining condition, which means that if you find non-Hodgkins lymphoma in an HIV patient, most likely his CD4 count will be less than 200. AIDS-related lymphomas are aggressive and most likely non-Hodgkins of B-cell origin. 60% are diffuse large B-cell lymphoma. Most patients will have a widespread lymphoma, not typical probably neck swelling or like neck lymph nodes. They will present by lymphoma everywhere, bone marrow, lungs, GI. Rare cases again of isolated pulmonary lymphoma has been reported, but as general, it's part of the lymphomatous process everywhere. You'll find it also in the lung. The Hodgkin's lymphoma is less common, less likely to affect the lungs, and is not AIDS-defining condition. The epidemiology is 2 to 5% of HIV patients might get non-Hodgkin's lymphoma. It occurs at all CD4 counts, as I said. It's been reported at all CD4 counts, but most frequently with low, less than 200. The frequency of pulmonary involvement ranges from 6 to 31%, so it's a very variable. You see lymphoma everywhere, and you look into the lungs, you might find it in a variable, probably in third of patients or probably less 5 patients, so you never know what is the exact incidence of pulmonary involvement in that lymphomatous process. As we said, the isolated pulmonary only patient with HIV with isolated mass in the lung to be lymphoma, it is rare, so most of it is going to be somewhere else. Patterns, how does the lymphoma get into the lungs? They have some patterns. It could spread from an extrathoracic primary side or contiguous from a mediastinal lymph node. Primary lung disease, we said this is a rare part, or could be endobronchial involvement, typically the maltoma, which is the mucosa-associated lymphoid tissue, a lymphoma, or it could be a rare entity, which is a primary effusion lymphoma, which is only causing pleural reaccumulation of pleural effusion. The AIDS-related pulmonary lymphoma, as is there's extrathoracic and there's a primary pulmonary lymphoma, which is less common. The manifestations are probably B symptoms as usually for lymphoma. Non-specific respiratory symptoms, cough, dyspnea, pleuritic chest pain is probably non-specific. About 80% for those, so you can see that this is less likely to have B symptoms, but I don't know if this is specific enough. The endobronchial involvement is 20% of pulmonary lymphoma. So this is kind of high numbers. So if you have a patient with lung involvement, he's going to have 1/5 of them will have endobronchial lesion. They will cause recurrent pneumonias, obstruction, or hemoptysis, as I saw just one case yesterday with the whole left main stem was surrounded by lymphoma. Rarely the endobronchial, rarely it will be causing complete occlusion, but last year we had another case which needed multiple stenting to keep that lymphoma open in the bronchus. The good thing that lymphoma is chemotherapy responsive, so you give chemotherapy and probably you can lose that stent fairly soon. And doesn't have a lot of constitutional symptoms if it's only endobronchial involvement. But most likely you would see it's a big mass, the hilar lymph node are huge and just compressing the airways. The pleural involvement of lymphoma can be just a direct extension from the lung parenchyma or secondary to mediastinal lymph node involvement, just obstructing the lymphatic drainage. And the primary effusion lymphoma is very rare. Effusions may be unilateral or bilateral. They are exudative, high lactate dehydrogenase, lymphocyte predominance as well. So I don't know if it's very specific, but the malignant cells can be catched on cytology, and you might be able to have enough cells to do flow cytometry. Imaging, again, not terribly specific. You can see multiple nodules, isolated masses, or diffuse. This is the nodules here. Maybe those are masses here of lymphoma. You might see if it's the case we saw had a parenchymal involvement and it showed a dense consolidation with air bronchograms, like a very thick pneumonia. And it is PET positive, of course. Bronchoscopy is almost always done for those patients. First of all, you want to look at the airways, rule out obstruction. Also, you can do biopsies for lymphoma, although the needle aspiration doesn't give you a lot of tissue, but it's probably good enough to make the diagnosis. You would also want to rule out other cancers. As we said, other cancers the HIV patients are at risk of other cancers. You want to rule it out. Potential infection also could rule out if it's a consolidation pneumonia only. If it's consolidation and there's or lymphadenopathy, you think could this be a consolidation or just a lymphomatous infiltration of the lung parenchyma with reactive nodes? You can't figure it out. So you want to do BAL, rule out infection. It's not there. Do your transbronchial biopsies, and usually, if you have accessible lymph nodes, you might also sample that. The optimal therapy is not well known, but a couple of points here. The antiretroviral therapy does not improve the lymphoma, but gets the patient in a better immunological state to withstand chemotherapy. The HIV seronegative population, you know that the choice of chemotherapy is determined by the type of non-Hodgkins lymphoma. For most patients, we're talking about HIV, they will have the diffuse, as we said, 60% diffuse large B-cell lymphoma. The CD4 count are probably usually low. The usual therapy is R-CHOP chemotherapy. After they give them a little bit of antiretroviral therapy, just do not to decrease the immune, because they will be neutropenic. The incidence of lung cancer is higher, and as we know more right now that HIV and AIDS patients do have a lot of lung complication. Interestingly, the lung cancer has 2 to 4 fold increase in lung cancer, and risk of lung cancer in those HIV population. Even if you correct for smoking, high risk behaviors in those patients, IVDA or smoking cocaine or marijuana, you still have a high risk, and it's also reported the risk might be related to the carcinogenic effect of the HIV, the medication, the increased risk of behaviors. So no clear etiology. The degree of immunosuppression is not related. So patients who may have any type of CD4 count but still at risk of lung cancer. And interesting also that the histopathological lung cancer is the same as a normal population. So the most common is adenocarcinoma. The Infectious Disease Society does not recommend anything regarding screening for lung cancer in HIV population for primary care guidelines. And worth mentioning that the National Lung Cancer Screening Trial did not exclude patients with HIV. So that means that screening may apply for smokers, HIV patients with low dose CT scanning. But risks and benefits of positive results has to be addressed before doing that. Castleman disease, I don't know. It's a angioproliferative lymph node hyperplasia. It's a heterogeneous group of rare lymphoproliferative disorders associated closely with HIV and herpes virus. There's two different disease entities, the unicentric and the multicentric, two different prognoses. Usually presents the same thing, non-specific weight loss with B symptoms. HIV patients, they have multiple involvement, and they most likely have the multicentric disease. You need to do an excisional biopsy of a lymph node. It will present as a lymph node that will get large as a mass. There you'll find polyclonal expansion of the node, polyclonal nodal expansion, and the structure, the lymph node will be intact structurally. The treatment is excision if it's in only one place. Sometimes they give immunotherapy with interleukin-6, combination with chemotherapy for the multicentric, and this is one example of multicentric Castleman. It's a mass, and this is an incidental finding. It's not necessarily in an HIV patient. Incidental finding here, you biopsy it, and it's Castleman disease, and then treatment is taken away, plus minus chemotherapy or immunotherapy. HIV-related lung complication, interestingly enough, also that the HIV itself causes emphysema, so it causes lung cancer, probably related to lung cancer. I would say it will cause. It's not a causal relationship, but it's a relationship. HIV lung cancer and HIV-related emphysema. Why do they have emphysema? We're not entirely sure, but we will talk about some mechanisms later. The bullous disease was reported when they were CAT scanning patients in the AIDS patient in the 1980s. They were doing X-rays and they were noticing there's bullae, there's emphysema there. So they noticed that it's centrilobular distribution, similar to patients with COPD, emphysema, COPD patients, and reported that about 4% of deaths among HIV patients. Interestingly, I think this is a high number, but it's related to obstructive lung disease. This is reported in 1998. 4%, not from an infection, just from COPD. It tends to occur at a younger age, so it's like an aggressive emphysema, and at a much shorter duration. Patients will have a 30% patient with HIV, they'll present with emphysema. The management, I don't know if we have anything different, so we'll stick with the same guidelines for regular emphysema COPD, so it does not change. And this is some of them, yes?
Are they smokers too, or?
It's even non-smokers, but most of them, even if non-smokers, are at risk of emphysema. So those are some of the mechanisms involved. So the excess risk behavior is one of them, but you have the role of other mechanisms, including susceptibility to infections, aberrant inflammatory response, antioxidant balance is broken, increased apoptosis, and this is a controversial role of antiretroviral therapy. It could be the direct effect of the drugs or a modified immune inflammatory response to colonizing pathogens, or could produce some autoimmunity. So we're not sure what caused it, but we know that it's more common.
You know which class of drugs? PIs or?
What are you talking about? No, I'm not sure if it's... no, I haven't come... They all antiretroviral therapy doesn't specify any class. If it does, I didn't come across of that. So it's a very big topic here in HIV-related ILD, so I just put one slide of it. I think this is enough, and it's probably... it's broad. You can find a lot of stuff in HIV, but the most common is to rule out the common stuff. This is like zebras. But you can see the lymphocytic interstitial pneumonia is a very common association. We're talking about LIP. You say, okay, it's caused by probably connective tissue disease, and then second thing jumps to your mind is lymphocytic interstitial pneumonia in that HIV patient. You will see, interestingly, sarcoidosis in patients with HIV, and for unknown reason, you will see you will see the numbers of you will see more sarcoid in HIV patients. It's not related to the CD4 count, so the decreased immunity is not one of the reasons that they get it. Interestingly, in sarcoidosis, this is usually higher. I've read it's only 200 here, but for some reason, if you're having HIV and your AIDS and your CD4 count is low, probably 50, you're not going to get sarcoidosis. So it's good prevention from sarcoidosis. An interesting point. I'm not sure what does it mean, but the rest is variable CD4 counts. You can get hypersensitivity, pneumonitis, cryptogenic, organizing pneumonia, LIP, and NSIP. Now I'm going to spend a lot of time here, but HIV-related pulmonary arterial hypertension is rare, 1 over 200. Might get elevation in pulmonary hypertension. The mechanism, how does HIV make pulmonary artery hypertension, is uncertain. But when they did the biopsies and the histopathologies, the typical lesions, the plexiform lesions, they are the endothelial cells, the abnormal endothelial cells, the intimal disruption, the medial hypertrophy, thrombosis, and recanalization. It's present in HIV-related pulmonary hypertension, and this led to the grouping of HIV pulmonary arterial hypertension in group 1, because they do have the hallmark histological pattern found in group 1, which is the plexiform lesions. Now, most patients have known HIV infection, and they will come up with new symptoms. So it's good to keep in mind that patients with HIV, no infection, no shortness of breath or dyspnea, might be worth to look at his pulmonary hypertension, to look for pulmonary hypertension as a reason. Of course, you want to rule out groups 2, 3, and 4, and 5 of pulmonary hypertension to say it's HIV related. It doesn't have obstructive sleep apnea, CHF, or other reasons, or sarcoidosis. The outcome is poor compared to other groups, and antiretroviral therapy will not improve the outcomes. Therapies, same as for group 1, you just give them group 1 therapy. And thank you. Try to talk